So Anne is going to present the case, our GI fellow. Anne?
No, we can't.
Okay.
Yeah. All right, well, we can't do this.
All right, so we have a case of infected right-sided fluid collection. This is a 69-year-old man with hypertension, diabetes, CKD, and significant alcohol history who presented with abdominal pain. He has a history of over 1 month ago. He was hospitalized with what was called gallstone pancreatitis. At that point, a percutaneous cholecystostomy tube was placed. On the 11th of this month, CT was done at an outside hospital. It showed diffuse atrophy, calcifications of the pancreas, a cholecystostomy in place, and a decompressed gallbladder. There's a peripancreatic fluid collection in the lesser sac measuring 5 by 9 by 8 centimeters. There's also a right psoas fluid collection measuring 14 by 25 by 10 centimeters and a right inguinal fluid collection. These all appeared to be connected, with the right inguinal collection being 6 by 10 by 11. He also underwent percutaneous drainage of the right lower quadrant abscess and a cholecystostomy exchange by IR. The fluid aspirate was growing out non-hemolyticus strep and possible Enterococcus species. He underwent an MRCP showing no choledolithiasis, and then underwent another CT 4 days later showing a decompressed gallbladder, but however the fluid collections had largely remained unchanged despite IR drainage. Dr. Binmoeller?
90? Okay.
So we're back with you, Ken.
Okay. Well, I'm so happy that I have this great panel and you, Muen, to help me out here, because this is going to be
it's a tough one.
require
Yes,
some thinking cap work here. All right, so there's not an obvious walled off, well-walled off fluid collection here. What we're looking at here is ill-defined. There definitely is. So firstly, let me just introduce by saying I'm in the stomach. Let's show first the endoscopic view, just so you have an idea where I am. So I'm here in the stomach, and it's fairly low down. I'm going to pull back a little bit. Yeah, I'm fairly low down in the stomach. All right, now let's switch to the EUS view, just so that we have an idea of orientation. And we're looking here at a poorly demarcated area. Very heterogeneous, but you can see, if we magnify, you can see there's this starry sky appearance, a lot of loculations inside of here. And what I've learned over the years is that when you have an infected fluid collection, early on it looks like this. Later on, it starts to have greater echogenicities inside of it. So even though this is not well demarcated, you really don't see a well demarcated wall, but what we know is that this patient has infected collection that is quite extensive, that extends right down into the pelvic gutter, and he had percutaneous drainage done, and he is sick. He's not getting better, and I think because he has a percutaneous drain in, my proposal is that we're going to put a LAMS in here, a large one, and we will create a closed circuit so that we're infusing the percutaneous drain and flushing out through the transgastric LAMS.
Ken, is the percutaneous drain in this same collection?
So I can't say for sure because the percutaneous drain is in the right lower quadrant in the pelvic area. He has.
I know you don't use fluoroscopy, but do you have fluoroscopy right now? That will help.
We could. I'm not sure that it's going to make a difference because in terms of, we could definitely, my preference would be to have the IR folks do that, and they can then see how much connection there is. I mean,
Yeah, so Ken, we see this after percutaneous drainage because through the drain, the fluid comes out and you're left with the solid. And so what I would do under fluoroscopy is just inject some fluid. And I mean, you see the EUS scope in proximity to the perc drain, you know it's there, and fill it with some fluid makes your job much easier.
that's true, Muen. That's a great suggestion. In fact, I had told the nurses earlier I'd like them to irrigate now through the percutaneous drain so that I could see if we see some communication there. And of course, we could do with fluoro. Now, I don't have lead on. We could all lead up. We're in the fluoro room. Usually, with rare exceptions, we don't need to use fluoroscopy. So, but we always have the ability to resort.
If you inject, you're going to see bubbling right away, and you'll know you're in. So it's not. You really don't need fluoroscopy.
My suggestion, yes, exactly. So what I'd like to do now is let's get an Axios or a LAMS in here, and then I'm going to dilate it up enough, not too aggressively, but enough to get a scope through, diagnostic gastroscope, and then I can sort of get a sense of what the contents look like. And I will then have their radiologists then irrigate and inject contrast, of course, to get a better definition of what the anatomy is and how extensive this is. Right now, we just have our CT scan, as a guide for this. So in the interest of time, let's just get started, and we'll place the 20 millimeter LAMS.
Ken, we have a question from Adam.
Yeah, Ken, it's Adam. We just tackled a case just like this. Your lower quadrant stent, is it retroperitoneal? Is it the pigtail? Has it been in a while? We did exactly the same thing. Our plan was put the LAMS in and then maybe do a VARDS or put a esophagus stent through the lower quadrant and go both ways. But actually, with one or two debridement sessions through the LAMS, our guys were able to see the pigtail, so we knew, we probably didn't need to go farther. But that thing's just packed full of cottage cheese, isn't it?
Oh, it is. It absolutely is.
It looks worse when you have a perc drain because the fluid came out. Everything else is solid. So it just looks terrible like this. But if you flush a little bit, it makes it easier.
That's correct. All right, so now I'm going to bring the camera down so you can see what I'm doing at the handle end, and also you can see what my nurse is doing. So we're ready to insert the 20 milliliter LAMS.
Ken, can I?
By the way, it is a percutaneous.
Can I ask a quick question? Sorry to interrupt.
Yeah.
Are you worried about the landing, sort of the landing spot that you have, not in terms of getting in, but having enough out in front of you so that it doesn't shorten back too much? Or you think that whole thing is, I see.
Oh, that whole thing is a big.
Mostly just that one space, but it looks,
Yes.
it looks big enough. Yeah, it's deep.
It is big enough. It's quite extensive.
Yeah. I just came in. I was in another conference.
So I'm just going to try to pass on a few tips here. So I am going to I lure lock this to the channel. You can see that. Hopefully, let's bring the camera so you can see it. All right, so we're lure locked now to the biopsy port. Now, the first step is to advance the sheath out. By the way, my nurse has not connected the cautery up yet. So we're not going to do that until I am ready to step on the pedal to penetrate or puncture the collection. So my first step is going to be to advance this black hub here. So this is just working like an FNA needle. I'm going to advance the sheath out. So we have to unlock to do that. So I'm now pressing on. This is a swivel lure lock, by the way, so I can swivel it into orientation so that I can always see this. And there are even numbers here. So number 1 is on the black hub to push out. Now my first tip is when you push out, never push against resistance. That's so important because you can start to deploy the LAMS. So if you encounter resistance as you're advancing, stop, and you need to straighten the tip of your scope. And sometimes I even have to pull back into the esophagus to get it sufficiently straight. So that's what I'm doing right now. I've pulled back some, And let's go to the endoscopic view for just a moment, please, so that you can see. I'm going to watch, and as soon as I encounter resistance, I stop pushing. All right, so I got to pull back even further. It's got to go smooth. Now it's coming out, and now I can stop. You can actually see one of the micro wires there on the side. So these micro wires are what allow us to cut through the tissue with minimal coagulation. So the surface area of those micro wires is about 3% of the total surface area of this bougie ceramic tip here. All right, so now I'm going to go back to the EUS. I've got to recapture my image. Now the only drawback here is that I'm occupying all this space in my working channel with the sheath. So it takes a little bit more time to evacuate the gas. Of course, gas is our enemy here. So I'm just going to have to spend a little bit of time just pulling out the gas that I insufflated in to see the come out. And then in a moment, I should have a view again. Okay, there. And then I'm also going to have my assistant hold this position here of the scope. So you need a lot of hands when you do these
worry that
procedures.
with this much solid and kind of fat necrosis that you might not see the internal flange well on EUS?
Yes, that's possible. So a lot of this is kind of, you have to do this Skywalker-like, let the force be with you. So it's going to be a bit of a feel here, and I'm going to decrease.
If you have, the delivery system deep into the collection, you're going to have plenty in that you don't necessarily have to see
what
the
happens
flange.
sometimes is the flange doesn't open
Right, because of the solid.
Yeah,
You have to spend a little bit of time.
minutes.
Yeah.
But if you can't see it,
All
and you
right.
have fluoroscopy, it's a problem.
We're ready to pen. Look, this is a fluid collection down there. There are all these pockets. This is all loculated,
Yeah.
right? This is heavily infected. This has been going on for a month and a half. So this should have been done a long time ago. They're having a closed circuit and having movement. The patient also has not been undergoing percutaneous irrigations. He has a catheter in place, but it's only to drainage. No one's irrigating the collection. See, that is the mistake. You have to have movement. If you have stasis, everything gets infected, and this is what you end up with. All right, now you can see my nurse is now making the device hot, so please connect it. You can see up here the bright echogenic sheath, right? And I'm just going to sort of push up against the area I want to go. Right there. So you see it's tenting just a little bit. And I can swivel my body just sort of, again, to find the best location. And it's always, you see I'm on Doppler. So it's always good to make sure that you're looking. You may want to magnify up a little bit and just be really sure there's no vessel right interposed where you're going. So I'm going to mag out. And now I'm going to take the Doppler off. And now I'm ready to go in. So I'm using pure cutting current to go in. Now, there's not a fibrous wall here, so I'm not concerned about penetration. But when you have a fibrous wall, I will sit on the cautery for just a couple seconds before I push through. In this case, it's not necessary. All right, we're ready to go? Okay, I'm pushing in. You can see now I pushed it in pretty far. And now we can take the cautery off. I'm locking the sheath here. So I'm locking. That's very important. And now I'm ready to take off the safety pin. That's this yellow pin here, throwing that off. And now I'm ready to deploy the distal flange. So I unlock the gray hub. You can even see the numbers. So now I'm going up to number 2, and I'm pulling up. As I pull up, we're going to see the distal flange deploy. And I'm doing it very slowly, very slowly. And this is the part that you may not see so well. All right, so I'm still pulling, and I'm going to wait till it clicks. And it just clicked. Now, indeed, I don't see the flange so well. And Todd, that was exactly, this is the problem when you have a lot of necrosis. So I'm going to start snugging up. I'm pulling back. See if I can see the flange better.
Sometimes just back and forth, back and forth.
Yes, exactly.
Jiggle it, yeah, helps it open.
You're starting
I
to
think
see a little bit
Ken
of it.
knows a little bit about this stent.
Yeah.
Not for him.
Right, right. Well, this is what's important for the audience is that the more necrosis that's in there, the harder it is by echo. You know, they're easy
this-
when there it is, it's opening. When they're
It's there.
completely anechoic, it's really easy. And even though it's a really big collection, it's can be confusing for people that are first doing this as far as knowing, you know, where to put this thing.
All right, now the next step is keep your eye on the ultrasound image. Do not be distracted. Don't try to look with endoscopy. We're going to deploy the proximal flange in the working channel. So I'm just pulling back on that gray hub, right? I'm snugged up. That was number 3, to snug up the distal flange to the wall. And now I'm going to deploy the proximal flange. While I do that, I'm watching that distal flange. I do not want that distal flange to move. And we definitely don't want it jumping forwards, and we don't want to see it pull back. So I'm pulling back, and now it's deployed in the working channel. Now I can switch to the endoscopic view. So let's get the endoscopic view up. All right, now you can see it's a red out now because I'm really right up against the wall. But what I'm going to do with my body is I'm going to slowly turn to the right while I give gas, while I push out this flange.
There we go.
So you're going to
Nice.
see the flange
Plus,
open up,
then-
and there it is. Now the cottage cheese is already trying to get out. You can see this is thick pus. All right, now this is the next tip I want to share with you. Be very careful when you pull out the ceramic tip. This is the cable. You see the cable, and it's a very narrow lumen right now. We're going to dilate the saddle in a moment, but right now there is a risk that if you forcefully pull back, you may dislodge the LAMS. So you want to do that under direct visualization. So I'm going to very slowly try to pull back like this. See? I'm pulling back, watching, and I'm going to look for that ceramic tip here, and I want to keep it in view. I'm adjusting my position. This is maybe less critical for a fluid collection. This can easily happen when you're draining the gallbladder. All right, there's the ceramic bougie tip there, right? And we're going to just slide that right out. Good. Now I'm ready to switch out for a CRE balloon, and I'm going to do this using the echo endoscope because I have a beautiful oblique view of this. But then, of course, after
Sorry to
the
interrupt. We're
dilation,
going to
we'll
have
switch
to
out.
break here. And if you're going inside the collection, we may be able to come back, but they're waiting for us in Guayaquil. Okay, we'll keep an eye on what you're doing, and we might come back. Thank you very much for
Yeah,
the
look
beautiful
at this.
demonstration.
Strap on.
back to San Francisco with Ken Binmoeller to look further at the collection. Okay, Ken, you are live.
Nice.
Okay, so I have cleared out as much of the...
Ken, can you hear us?
Yes, I've cleared out. Can you hear me?
Nodded yes.
You can hear me?
Yes.
Good.
Yes.
I've cleared out as much of the pus and the cottage cheese as possible. My next tip is when you're in the PFC, minimize the insufflation of gas. You should really only be using CO2. And I do all of my inspection, evaluation, and cleaning underwater. So I'm just going to give little puffs of gas now so that you can see the anatomy. You can see the wall of the fluid collection to your left. You can see there's a lot of debris in here. Now, if this patient did not have a percutaneous drain, I would requirement. And patient has no choice. I would discuss this ahead of time. But since he has a percutaneous catheter, I think it's acceptable to irrigate through that and see how this evolves. But I'm suspecting that I'm
Lost your audio, Ken.
okay, sorry.
They're fixing them up.
All right, is it better?
It's a little scratchy. I think it's
Sorry about that.
just changed location maybe.
Good. Control room. All right. So now if I hopefully you picked I was explaining before that I would place a nasocystic catheter for continuous irrigation at 75 or 100 cc's per hour. In this case, I think probably I'm going to bring him back after maybe a week, and I'm going to perform powered endoscopic debridement, PED, using the endorotor. And we have a 6-millimeter channel gastroscope, so we can pass that directly through that large channel gastroscope. I have a 20-millimeter LAMS, so it should be easy to do. In addition, there is also a sheath attachment that you can apply to a standard gastroscope to pass the 5.1 millimeter diameter endorotor. So on my way out then, this is how it looks. And I've asked my nurse to inject some methylene blue through the percutaneous drain just to see if I can see any of that emerge from the depth here. Go ahead. So we might see something, but we may not because there's this so loculated and it's down in the pelvis. So she's irrigating down and just sort of
saline. Can you just follow the trail of saline as well, or no?
You could, of course, but the blue, of course, would be very obvious if you saw it trickling. So keep going. You got to inject a lot.
Yeah.
Yeah. So actually, if we had two pumps here, I would have this hooked up to a pump and really irrigate it well. Patient's going to go to the radiologist, so we don't see anything. So let's stop here. They'll define the entire anatomy. And then like I said, I think I'm probably going to be doing debridement here with the endorotor, the PED device.
Hey, Ken,
and the last
one important
yes.
thing you mentioned is irrigation, aggressive irrigation. And frequently we see percutaneous drains and they inject 10 cc's twice a day. So basically they're depending on them just to drain by gravity rather than aggressive irrigation.
Yeah, the problem that we have at our institution is we're recommending that's happening, and then the interventional radiologists that place the drain are saying, no, don't put that much in. And so there's this back and forth because they only use small amounts to maintain catheter patency, and we're trying to tell them, no, we want it really like. So,
but one thing I do is usually the medical or surgical teams are worried that you'll inject and the fluid will accumulate inside the cavity.
Yeah.
Show them communication. So the blue color is nice. You take a picture. Tell them they're communicating. So whether you inject, it's going to come up.
Right.
Hey, Ken, do you take them off PPIs and give them Diet Coke?
I don't give them the Diet Coke, but I do take patients off of PPIs. So that's been part of our standard protocol for a few years now, because the concept here is that the acid will actually contribute to the lysis of debris and necroses. Now, that has yet to be proven. Now, there is a theoretical drawback to taking the patient off of PPI, and that would be that potentially, if there's some vessels along the wall, maybe the acidity could contribute to bleeding. There's pros and cons, and we really need, I think, randomized controlled trials to determine it one way or the other in terms of the benefit. But yes, there are two things. Number one, off of PPI. Number two, I keep the patient on antibiotics until the collection has fully resolved, and then 1 additional week after removal of the LAMS. I do have patients already automatically scheduled to return at 3 to 4 weeks. Now, it doesn't necessarily mean that I'm going to remove the LAMS or exchange it, but I'm going to definitely evaluate and document that I've evaluated the LAMS at 3 to 4 weeks.
And what's your, when you have the luxury of a lavaging catheter like this guy, what do you like to put through it? Do you put some dilute peroxide, or do you just put saline? Do you use antibiotics ever?
Great question. So number one, I've learned that even though I'm a great fan of the hydrogen peroxide, been using it since my Hamburg days with Nib Sandra, and at the very end, I did put hydrogen peroxide in. You may have seen the bubbling up there. But the problem with hydrogen peroxide is it will...
We're going to go to another center. We only have 5 minutes.
Yeah, okay.
And,
aspiration risk, regurgitation.
To conclude the session. Thank you, Ken. We appreciate you participating with 2 amazing cases.
Thank you.
Let's go back to Virginia Mason. I think